The information shared on the Allo podcast is not intended as medical advice. Your medical care decisions should be made in consultation with your physician who is familiar with your specific case. Welcome to the Allo podcast from the Allo Hope Foundation. I'm Molly Sherwood. How are you doing over there, Bethany?
Hello, and I'm Bethany Weathersby, feeling opinionated over here. No, I'm just kidding, but I kind of am for some reason. Okay, so
never do. Always the same. Yes, no, always that case.
Actually, my boyfriend Chat told me that I was opinionated the other day.
Wow, if he said it, you know it's real.
I know, right? He's following my typing patterns of words. He's like this.
Well, I want to open with something that Chat suggested that we ask.
Okay,
I actually really liked.
I did too.
Because I was like, oh, I want to do this because this will teach me something about you that I do not yet know, of which there are very few things.
Right. And I don't think I know this about you either. So let's throw it out there.
All right. Okay. Listen, tell me the thing that you irrationally hate.
Well, there's so many. Okay, just one. The first one that comes to mind is when people use the word oftentimes.
Oh, yeah.
It's not a word. I don't think it's a word. Although my husband would be like, any word that people use regularly becomes a word.
Oh, that's so tolerant.
It's often. The worst. Oftentimes. Are we in the middle ages?
Now I want to look that up after this.
Oftentimes.
I can't. Man, now I'm thinking about all the times I might have said that to you. Well,
oftentimes. I can't even say it.
Mine?
No. What is it? I'm scared.
All right. Mine is so dissimilar to what you just said. But again, it is the first one that came to mind.
Okay.
And mine is that I hate watching people scratch themselves. It really bothers me. If I'm in the car, especially if I'm in the car and I'm with my mom and she starts scratching her forearm, all I can think about is dry skin flakes. Yes, the cells
that you're
floating around. Yes. I get so agitated. It really bothers me.
Is it only people scratching in your space? But what if the person in the car next to you, windows rolled up, they're having a scratch fest? Are you feeling some hatred?
No, if it's in my house or in my car, or it might float onto my body, I don't like it.
Oh wow, I've probably scratched myself many times in your presence.
A quick little itch, but going at it because your skin is dry or something. I can't.
What if you just carry some good lotion with you everywhere you go and just give them a little squirt?
Yeah,
and that will both solve the problem and give them the hint that you don't want to inhale their skin cells, please.
Thank you for that solution, actually. And I don't have a solution for your oftentimes problem.
I need to just stop being uptight and let it go. But look, okay, do you ever have, sorry, we're just going to follow this trail. Do you ever have an itch on your body that's very intense but you can't find it? You don't know where it is. You're like, oh, my shoulder's itching.
No.
And you scratch in the spot. And that's not the itch.
No, but I believe that would be a thing that could happen.
Yeah. It happens to me often.
Does that also make you irrationally angry?
Yes. I have an itch and I can't scratch it.
Oh, man.
It's like the opposite problem of your itch situation. Oh, okay.
Oh, man.
Anyway. All right. But I feel like I learned something new about you, and I'm going to be super careful not to scratch.
I'm going to be really careful never to say oftentimes ever again.
No. Oh, man. Okay. So let's move on. Oops, I just hit this, which means that was probably a loud bang. All right. Let's move on to our episode today. It's a shorty. Shorty what?
Oh, yes.
Right. Shorty got low.
Don't edit that out. Keep that.
Okay, no. Today's quick and nerdy mini episode.
Nerdy.
Yeah, baby. Is all about IVIG, intravenous immunoglobulin. That sentence went from crazy fun to nerd fest really
Yeah, it did.
fast. And this is, I think, in my opinion, this is one of the most powerful and most overlooked treatments in the hypothetical HDFN toolbox.
Yeah, I agree. And like our plasmapheresis episode, this is another bite-sized deep dive into a treatment that
Mm-hmm.
is not used super often, but when it's needed, it can make a huge difference. So if you have not listened to the plasmapheresis episode yet, hit pause, go listen to that first. It's a perfect companion to this guy. And we're going to
Mm-hmm.
keep it short, sciencey, and hopefully helpful. So let's jump in. The first things first, we're looking at IVIG as the next tool in our HDFN toolbox to try to delay the onset of fetal anemia. And by the way, in this case, we're talking specifically about using IVIG as a treatment for the mom in early pregnancy, not the same as using IVIG in a baby with HDFN, which we have talked about in other episodes. So, anyway, in the case of IVIG during an alloimmunized pregnancy, we already have intrauterine transfusions, which are IUTs, to treat fetal anemia. So, why do we need to be searching in the toolbox if we already have a tool for that?
Right. So, although IUT is regarded as a relatively safe procedure in experienced hands, it is still invasive and it's painful for the mother, it's stressful, and it poses serious risks to the fetus and occasionally the mother. But, if the baby is anemic too early in the pregnancy, that means there's a higher risk for that IUT procedure. The fetal loss rate actually increases if the IUT has to be done at 20 weeks or earlier, and if the IUT is performed after the baby already is showing signs of fetal hydrops, then the baby has a lower survival rate then too. And so it's actually very nuanced. There are all these different factors that go into the IUT, solving the immediate issue of fetal anemia. And so if all of those things are not lined up correctly, then risk increases. And so there's one study that actually showed, a recent study that showed that an estimated 13% of pregnancies that are being monitored for anti-D or anti-K required one or more IUTs, despite these recent advances we've had in identification and care for pregnancies at risk for HDFN. And this was really surprising. The rate of fetal hydrops in pregnancies requiring IUT was found to be 14.9% for women with anti-D antibodies, and then 39.2% in women with anti-K antibodies.
Wow.
That's very high.
That's really high. Yeah.
And so that shows that these IUTs are being delayed, right? And they're kind of missing that sweet spot where you can intervene when the baby's anemic, but before hydrops develops. And fetal hydrops has actually been found to be associated with impaired neurodevelopmental outcomes and lower survival rates. So yeah, it's just IUTs are not a perfect solution, unfortunately.
Mm-hmm.
Let's look at what is IVIG. What is it? So IVIG stands for intravenous immunoglobulin. Like I said earlier, it's a blood product made up of pooled antibodies from thousands of healthy donors. This just sounds crazy. These antibodies are filtered and processed into an infusion that can be given intravenously, so through an IV into the mother, and it's used normally to treat a bunch of different autoimmune and inflammatory conditions.
But when we're using it for HDFN, we're using IVIG in a way that's somewhat unique, and I think it's still considered to be off-label. And when we mean off-label, we're saying that we're using a medication that's been approved for use because it's been demonstrated to be safe, but it's been approved for use in certain other conditions. And so when you use it in a condition that it's not written on the drug label to be used, that is an off-label use of a drug that's already on the market and proven to be safe and effective. So MFMs sometimes use IVIG in alloimmunized pregnancies to try to sort of block or reduce or distract the mother's immune system, because in HDFN, the mother's body has made antibodies against the fetal blood cells. Those antibodies can cross the placenta and destroy the baby's red cells, which can lead to fetal anemia.
IVIG acts kind of like a decoy. And the idea behind this is that by flooding the system, by flooding the mother's system with non-specific antibodies from IVIG, fewer of the harmful maternal antibodies are able to cross over through the placenta and attack fetal cells. It's basically immune system redirection. Like, hey, look at all these totally harmless antibodies I just gave you. Just ignore those other ones.
Mm-hmm. Yeah.
Does that make sense? I don't
know. Yeah, it does. That's the hope anyway. And there was a good study that just came out in 2024 that compared the effectiveness of IVIG for severe HDFN against pregnancies that didn't receive it. And they did confirm that IVIG can help delay the onset of fetal anemia, especially, like we're saying, in these high-risk cases where severe disease is expected early in the pregnancy. And so that study found that using IVIG in the pregnant woman with a fetus who's at high risk of severe HDFN did have an association with later onset of anemia requiring IUT, which is great. That's a bigger baby. That might mean less IUTs, or it might mean just starting later. A lower rate of high drops at the time of first IUT, and you just talked about how we want to avoid high drops. A lower risk of fetal demise, which means fetal death in utero, and live birth at a later gestational age of pregnancy.
Wow.
So
those are
good things.
That's a big deal.
Yeah.
Yeah.
So, okay, who gets IVIG? So not everybody would necessarily qualify to receive IVIG. Generally, it's recommended for patients who had a previous baby with severe early onset HDFN, especially if that baby needed an intrauterine transfusion before 24 weeks, or if the pregnancy ended in fetal loss due to anemia. And it's also considered when a mom has a very high antibody titer early in pregnancy, particularly with antibodies like anti-Kel or anti-D, but Kel especially, which can be more destructive.
And IVIG is sometimes used in combination with plasmapheresis. I think we touched on this a little bit in the plasmapheresis episode. So often in the most severe cases, this is combined like this. And the plasmapheresis helps lower the maternal antibody titer by physically removing antibody-rich plasma from the mother. But like we said in the plasmapheresis episode, the mother's immune system often rebounds and then makes more antibodies. And so that's where IVIG comes in and can be really helpful. It's typically started right after the final plasmapheresis session. Well, the day after, not like that same day, but the day after you finished the last plasmapheresis session. And the IVIG helps kind of blunt that immune rebound and keep the antibodies low as possible and hopefully delay that fetal anemia. IVIG can also be used alone without plasmapheresis and can still be effective. And to be clear, we don't usually see antibody titers drop significantly with IVIG alone. I think occasionally they can, but usually we don't see that. And the goal isn't necessarily to lower the titer. I mean, that's nice, but the whole point is to prevent or delay the need for intrauterine blood transfusions, and keeping the baby safe from the mother's antibodies very early in the pregnancy. And this is kind of weird, but when I had IVIG and plasmapheresis, my titers always rebounded to where they started, 1024 or 2048. But the treatment still worked. They were very effective in delaying that anemia, even though my titers were the same as they were with Lucy and no IVIG. So it was still working despite my high titer levels. So kind of interesting.
Okay, so folks are probably wondering what treatment really looks like if they were to receive IVIG. So IVIG is given via IV infusion, hence the IV, usually once a week, starting around 10 to 12 weeks gestation. And it's super important to do it at that time because IVIG is a preventative measure and it works best when it's started before the fetus becomes anemic. So, as we've said in previous episodes, the goal is to get there before the antibodies do. And a typical dose is 1 gram per kilogram of maternal weight. And then the infusions continue until the baby needs an IUT or until delivery. So some providers might stop IVIG infusions once the pregnancy has reached a gestational age where IUTs can be performed if needed, usually around like 20 to 24 weeks, but that approach is less common. And so, in terms of who might qualify for IVIG, we've talked about the new consensus guidelines for the management of alloimmunization and HDFN. And I think we've already touched on this, but it's important to repeat in the context of this episode, which is the major win of having guidelines that recommend a situation when IVIG is warranted, when previously a lot of clinicians would not offer IVIG unless somebody had a history of previous loss. So now the guidelines do recommend the use of IVIG in patients with an antigen positive baby who have a history of either fetal anemia or loss due to HDFN before 24 weeks in a previous pregnancy. And they also suggest the use of IVIG in pregnancies with an antigen positive baby and when the titer is high. So a titer of 512 or higher for anti-D or 64 or higher for Kel, regardless of prior pregnancy history. So this eliminates that crazy hurdle of patients like you, Bethany, having to hear from their doctor that you can't have this treatment until you've lost a baby.
Wow. That is so exciting to have these new safe guidelines in place. This is amazing. If that had been in place and implemented during my first Cal pregnancy, my daughter Lucy would probably be alive. So, all right, let's look at the safety of IVIG. IVIG is considered to be pretty safe in pregnancy. Like we said earlier, it has been used for decades during pregnancy for lots of different conditions. And so I will say, though, that it's not without potential side effects for the mother that can be really unpleasant. Common side effects include headache, but really for a lot of us, it's like debilitating migraine. I'm just going to be upfront with you. It's a really, really bad headache. It's not just headache. Fatigue, chills. For me, it was vomiting. Some women have nausea or, flu-like symptoms after the infusions. And these can be managed with pre-medication like Tylenol or Benadryl. Some providers like to use a steroid also before the infusion for the mother. And then you can ask for a slower infusion rate, and that often helps lower the side effects and try to stay hydrated. And personally, I took a medication called Fioricet for my really, really bad migraines after IVIG. And I also continued taking my Zofran for nausea. That really was essential for me because I also had hyperemesis, even without all of this added to it. And these are medications my MFMs prescribed for me. And so if you are really having these painful side effects from the IVIG, definitely talk to your MFM about some potential solutions. It really can help. And IVIG is also expensive. Hopefully your insurance will cover it. But yeah, that can be hard if for some reason insurance won't cover it. And often you have to start that insurance approval process very early in the pregnancy, like right after you get that early, 6-week ultrasound showing baby's doing well. And we have actually seen so many beautiful, healthy outcomes in some of the most severe cases with the help of IVIG as an additional therapy, of course, added onto expert providers and proactive care that they are supporting their patients with. And as our listeners probably know by now, I had IVIG with my 3 youngest children, and I had very aggressive anti-Kel antibodies. And they had IVIG after plasmapheresis, and their first IUTs weren't needed until 24 weeks, 28 weeks, and 25 weeks. And their older sister, Lucy, that was my first sensitized pregnancy, we did not have these therapies, and she was severely anemic by 17 weeks. And her starting hematocrit in her IUT at, I think it was like 17 plus 6 or 18 weeks, her starting hematocrit was 6. And so the other babies who had IVIG and plasmapheresis, their starting hematocrits during their first IUT were 26, 28, and 25. So that's very different from Lucy's hematocrit of 6. And then Lucy also had fetal hydrops, and the other 3 did not develop fetal hydrops. And of course, the main difference was that Lucy was so severely affected, she did not survive. The other 3 survived and are totally healthy and thriving today. And that is massive life-saving improvement. And I wish every woman who really needs IVIG could have access to it.
Your story is the perfect, I mean, it's its own case series, you know? You have
Yeah, I
your
know.
own.
I know.
It's the Bethany study.
When I was looking for case studies on this. I read one and I was like, this sounds too familiar. And then I realized it was me. It was mine. And I forgot.
Just secretly famous.
It was just, yeah. No.
So
Okay.
so one thing I think people ask is, why don't clinicians automatically offer IVIG to their patients who might qualify? One reason is there is still no large randomized controlled trial on the use of IVIG for this purpose in HDFN, which is quite unsurprising in that this is a very rare disease, and most of what we operate from for the management of this disease is also not dictated by randomized clinical trials.
Yeah.
Maybe one day. And it's also expensive and logistically tricky. And many providers hesitate to use it unless there's a very strong justification. And, you know, also we're talking about a very specific subset of people who may be eligible within an already rare disease. So some providers are just not aware of this as a potential option. And it can feel like a risk to try something new on a patient that you've not done before in this way.
Right. Yeah, that makes sense. And I think this is where shared decision making comes in, right? So if you're a patient with a history of early severe HDFN, or if you have a super high titer, it's definitely worth bringing up IVIG to discuss with your MFM. Try to bring it up early. Honestly, it's best right at the beginning of your pregnancy, or even better, in a preconception appointment before you become pregnant, so you can kind of lay out the plan and feel really confident moving forward. And as we all know, timing is crucial with this disease and with this therapy as well.
And if you're a provider, we would encourage you to consult with colleagues, review the available literature on this, and keep an eye out for the new guidelines on the use of IVIG that we just mentioned. Which are being published this year, that recommend the use of IVIG in cases with a history of fetal loss due to HDFN or development of fetal anemia prior to 24 weeks in a previous pregnancy, or an extremely high titer like 64 or higher for Kel or 512 or higher for D, regardless of prior pregnancy history.
Just a reminder for our patients who might be needing IVIG, remember that it's really good to plan early. These infusions often need coordination and insurance approval. And if you're having these infusions, to mitigate side effects, you can hydrate really well before, during, and after each infusion. And while you're having the infusion or afterwards, speak up if you're experiencing side effects that you're concerned about or that are really affecting you. You know, tell your infusion nurse or your MFM if you're having rapid heart rate, shortness of breath, headaches, or other concerns. There are lots of different ways that they can help you manage those. And remember, you can ask your nurse to slow down the rate of your infusion. And something interesting is that the longer you have these weekly infusions, the less severe your side effects become. It's kind of like your body adjusts, and then usually after a few weeks in, you don't have any side effects. And so also another tip, you could ask your MFM about using a home care nurse to administer your weekly infusions at home. That's what I had, and it was like a game changer.
That's super helpful. And also just knowing that you're not alone. You're not the only person who's experienced this. Many other alloimmunized moms have walked the IVIG road and are ready to support you. If you're not a part of our online patient support community, come and join us on Facebook. Our group is called Antibodies in Pregnancy, an AHF support group.
Yes, come join us. And as always, if you need help finding an expert or help navigating your care, please reach out to us at the Allo Hope Foundation. We're here to help.
And don't forget to check the show notes for links to studies, guidelines, and other episodes that pair well with this guy.
Yes. Okay. That's such a hard
I know,
entrance.
it's like a harsh exit. Well.
Oh, yeah, entrance. What am I saying?
I think we're ready. We're just tidied up this nice and neat episode.
Yeah. Okay. I'll finish us out.
Okay.
Whether you're a patient, provider, or otherwise affected by antibodies in pregnancy, we are here for you. We have great resources on our website at allohopefoundation.org. That's allo spelled ALLO, hopefoundation.org.
Thanks for listening.
The Allo podcast is offered by the Allo Hope Foundation, a nonprofit organization. This means that our ability to continue this work depends on corporate sponsorships, small research grants, and donations. While sponsorships and grants are vital, they're often restricted to specific activities, and they do not cover the everyday work that keeps our mission moving. Things like creating educational materials, writing grant applications, running our social media, and especially managing our rapidly growing patient support group where we counsel women every day. They also do not cover the direct support we provide to families who cannot access life-saving care, whether that's the cost of an antibody screen in Kenya or bus fare for a mom in the US who needs to travel for an intrauterine transfusion. If you've ever wondered whether a donation of any size makes an impact, it truly does. Please visit our show notes for information on how to donate to AHF or to become a recurring donor. Your support gives our small organization the stability we need to continue this work and ensure no family faces HDFN alone.
Welcome to the Allo podcast from the Allo Hope Foundation. I'm Molly Sherwood. How are you doing, Bethany? Was that weird?
Oh, sorry.
Eric told me to do. I can't. It was weird. Otherwise,
no, I'm sorry. I can't. I have no words.